Good morning. My name is Małgorzata Mojsak. I'm accompanied by Amelian. We are very happy that we can take part in this event. We represent the Medical University in Bialystok. And during this lecture, we would like to talk about PET-MR technique, and we would like to say what we can do to keep a high quality of the images. This is our lab. We have a PET-MR since 2014. The first study exam was made in 2015. Simultaneous PET-MR 3D. It's the same device, but there are different photos. Our lab is quite specific because we are in the Bialystok Technological Park. We conduct the exams for the purpose of science. PET-MR is not a refundable technology. We also teach students. So we deal with scientific and didactic activities. When it comes to PET-MR technology, just like PET-CT, this is a hybrid technique, as Professor was saying. So so we've got two components. So depending on the tracer, PET-CT, PET-MR is hybrid imaging technology. PET-MR is used in multiparametric imaging. Additionally, in PET-MR imaging, the resonance is not only the imaging that provides anatomical or morphological information or the information on the location of lesions. Additionally, it's a technology that is diagnostic, and when we conduct PET-MR, we receive information for PET from images from different sequences, so we obtain additional information provided by MR on morphology, on anatomy. We also receive information from different sequences of the images on the homogeneity of lesions, perfusion, cells density, and as the professor mentioned, we are using different techniques that increases sensitivity and specificity. So when we talk about PET-MR, we are talking about multiparametric imaging. It's not only focused on PET, and resonance also provides a lot of diagnostic information. So here you can see some functional images. So this is the multiparametric imaging. Since this technology, before the scanners were developed, there were discussions whether PET-MR is going to replace PET-CT. What's the share of PET-MR in the hybrid imaging? So PET-CT, it was decided that these two techniques should complement each other. So will be different groups of specialists who should create some key criteria for the specific areas, and definitely PET-MR is of greater value than PET-CT. So it had to be decided which technique will provide which aspects. So the key differences between these two techniques in PET MR case, we can say it's an innovative technology. The first exams were performed in 2011, the whole body exam. It was performed in 2011, but there are not that many PET MR devices. There are some 120 installations, so this is not a huge number. This exam is not refundable in many states. That's why it develops more slowly. So PET MR is treated as innovative technique.
And actually, this technology should be applied in specific cases. Another difference is multiparametric imaging. So first of all, this is the specificity of this technology. Another important aspect is the fact that the PET MR has a very low ionizing radiation dose, and the research in Essen Center, where 100 patients were analyzed, and the dose of radiation was examined, and it was about 70% lower dose compared to the PET-CT technique. And as Professor Krulicki mentioned, PET MR has a better soft tissue resolution. Could you speak a little bit slower and closer to the microphone, because we are having simultaneous interpretation? So when talking about imaging, well, PET MR is more sensitive and is better for imaging soft tissues, has better resolution for soft tissues, which results from the imaging itself. So in this case, the better quality is used for imaging brain, liver, as well as pelvic imaging. However, we need to bear in mind the fact that in case of PET MR, we have more contradictions compared to PET-CT technology. And here we need to speak about these contradictions. The main contradictions include metallic objects and claustrophobia. In case of PET-CT, it is pregnancy. So, as you can see, PET MR has more contradictions compared to PET-CT. As I said, metallic objects and claustrophobia. Especially if you have a patient is equipped with some metal protheses or some implants that are no longer used that frequently, but there are still patients who have such objects, and they cannot be applied this type of examination. And actually, we can also apply such an imaging examination when seated in a small scope. PET MR examination takes longer time. It's not a best solution for patients that are suffering from severe disease and are in a very bad condition. So we cannot use this technology, but we should apply PET-CT technology instead. So PET-MR technology differs from PET-CT, but there are different applications. When we take into account the PET-MR key applications, we can speak mainly about the applications that should be that are decided by a group of experts to be applied, that assessed a large population of patients, and they proved that PET-MR application should be used rather than PET-CT for SNC, head and neck tumors, breast cancer, abdomen, especially for liver lesions, and also for pelvis, and here especially prostate cancer, female pelvis and rectum. Also bone tumors should be examined with PET-MR scanner, and also NET, especially in children, and lymphoma. So these are the cases that are the proper, these are the diseases, the lesions that should be scanned with PET-MR apparatus, especially children. Children are young patients and we need to apply low doses. And in case of lymphoma patients, these are mainly young patients. And as we know, in case of lymphoma patients, expert groups advise that PET-MR technology should be applied. The first publications with the use of PET-MR images occurred in 2007. And these are PET-MR images of brain. Here you can see 2009. So 3-TMR brain PET was applied in May 2009. And these were really the first research examinations. They were not routine clinical examinations. In 2010, the first installation of integrated system PET-MR, the whole body examination was performed. So the first examination, simultaneous PET-MR examination was performed in 2011, and then it all developed very, very quickly. So here you can see that the resonance and is now in one equipment, is together with the whole scanner here. But before we had a sequential PET-MR scan. So the PET part and MR part were a little bit apart from one another. So it was really hard to put it together in one piece of equipment, because photomultipliers did not play their role in a proper way. It was very hard to obtain a proper image. But then multipliers were changed, and now they are all together in one scanner. And it allowed us to perform the integrated system examination of the whole body, as I mentioned before. But these were the examinations performed with simultaneous PET-MR scanners. And after that, in 2012, the first publication occurred, and it showed that this technology is not worse than PET-CT technology. It's not, it did not stress that it is better, but it is not worse than PET-CT technology. And actually, the first data acquired showed that this PET-MR technology in patients in oncological diseases allowed for much more detailed detection of the lesions compared to PET-CT. Well, there were some disadvantages of PET-MR that Professor Kulicki mentioned. So the attenuation correction approach technology, and we can speak here of some difficulties which is the measurements of SUV and TLG, whether they are comparable with PET-CT technology, whether these are compatible and comparable values and the activity of tumor changes can be compared between various techniques applied. But after the first in this first publication, it showed that the correction is the proper methodology applied in PET-MR technology, and I know that the research is still being carried on. So actually, there were three aspects of PET-MR imaging that are constantly questioned and discussed. As I said, it is PET-MR attenuation correction and the comparison of quantitative analysis between PET-CT and PET-MR that might be problematic. In case of PET-CT attenuation correction, there's Hansfield degree that is used for describing gray area. However, in PET-MR, we cannot use it. So actually, PET-MR provides a better, much easier attenuation correction. Another aspect that is being discussed is comparison of quantitative analysis of PET-CT versus PET-MR. And in 2023, the first consensus and first guideline occurred. It was developed by International EANM SNMMI ISMRM. And this is the recommendation of PET-MRI application in oncology. So these are the key applications that I discussed. So actually, PET-MR is not as good as PET-CT, but it seems that PET-MR is much better in providing the information for the treatment of patients suffering from these key application diseases. Then we have the motion correction. There are different sensors that we apply, and we can correct all the artifacts connected with the motion. And here we use the algorithm of artificial intelligence and allow us to better control the breathing motion. However, in terms of attenuation correction methods in PET-MRI, it is MR-based methodology. So we apply the acquisition of the whole body with the use of Dixon-based four-segment map. And looking at this map, at the structure of the body is segmented into 4 types of tissues. So background air, fat, muscle, and lung tissue. And then we correlate proper gray scale, and the attenuation correction is applied. In case of Hansfield correction, we cannot use a special number of degrees, and this type of correction in PET-MR seems to be sufficient, and it is not only used in our laboratory but also worldwide. There have been also other methodologies suggested in order to apply proper attenuation correction. For instance, emission of PET technology. So based on the values acquired from PET apparatus, but I don't think we are going in this direction. Another proposed methodology of attenuation correction method is the methodology based on Atlas-based methodology. And there was a database developed for the whole human body for a given patient, and the best model of a human organism should be applied for a given patient, and then the proper attenuation correction method should be applied that was developed for this particular type of the body. And it seems that it is also not the best way, but now the best method that has been proved efficient is machine-based methodology. So it means that our apparatus, our scanners should get the knowledge, machine should get learned what type of attenuation correction method should be applied in a specific case. So when we compare the quantitative analysis of PET-CT versus PET-MR, then numerous publications show that these analyses are comparable. When we take into account the SUV in bone system, this area has been taken into account when examination of images, but in many publications it has been proved that the quantitative analysis in PET-MR and PET-CT are comparable and can be compared against each other. We also carry out a research, and in one patient we make PET-CT and PET-MR examination, and it is really true that the SUV values are comparable. However, what is the key here is to normalize, standardize the SUV parameters in order to achieve the high quality of the examination and to make sure that the two technology applications can be comparable. And now I would like to give the floor to my colleague, Anna Amelian, who will give you more information about that. Good morning, ladies and gentlemen. Let me say a few words about certification. The initiative of certification of this methodology was initiated by European Association of Nuclear Medicine. Could you sit, please, closer to the microphone and speak a little bit slower? So this is the accreditation, and this initiative started in 2006, and it was initiated by European Association of Nuclear Medicine. And the first certification could be obtained in 2010, from July 2010. And I will speak a little bit more about the types and the requirements and how to get such an accreditation. Actually, the primary mission is to enhance the quality and consistency of nuclear medicine practices and to make sure that these examinations are repeatable between scanners and patients. In 2010, the first article occurred, and it provided the guidelines, the procedure guidelines for PET imaging. And 5 years later, another article occurred, and it provided revised data and more information about further development of the accreditation. What it spoke about what was the including new isotopes, so not only the previous isotopes should have been used. Here you can see the description of the harmonization of the PET quantification methods, and they show how it should be obtained step by step. what is the goal of this initiative, of the accreditation initiative? Well, as I said before, the main goal is to provide a special standardization to promote uniform imaging and data acquisition protocols in all nuclear medicine practices. Then quality assurance. We need to make sure that the images are of top quality. Apart from that, it is important to educate the personnel, train those who carry out such examinations, then research support and clinical translation. All these goals are provided in the EARL manual. Here you can see the manual for this accreditation, and it provides the certification step by step. So you can always contact directly EARL team if you have any doubts, if you have any questions. I'm sure the experts that will provide you with with proper information and provide you the guidelines what to do in order to make sure that we use our scanners properly. Now let me say a few words about the types of accreditation. As you can see, they have changed over time. So in July 2010, we could get the accreditation for standard 1 and 2. So it was a PET-CT with the use of fluor 18. Only in 2020, we could get the certification for PET-CT with zircon 89. In 2021, it was PET-CT with Ga68, and then in Q4 2021, it was the use of Hoffman 3D brain phantom images that could be used and applied. And here you can see this phantom. You can see the gray matter comparison versus white matter. And then in third quarter of 2022, we could see another certification. And so there were two different standards in Q1 and Q3 for Zinkern and Garland. And in our laboratory, we have the certification in 2022. So we have the proper accreditation and certification for standard 1 and 2. Actually, it is not enough to get the certification just once. It does not stay forever. Actually, regularly, we need to provide the reports, the images to the team, and the certification is renewed, the accreditation is renewed. I will show you how these images should be sent and which phantoms should be used. Accreditation process starts from the enrollment by sending the application form, and we put the name of our institution, the information about the scanner that we would like to get the accreditation for. Actually, the certification is provided for a given institution and for this particular scanner. So if we have 2 scanners in our institute, then we need to obtain 2 certificates, 2 accreditations. And as I said, this is a continuous process, and we need to keep sending the images constantly. And additionally, an invoice for accreditation fee is sent to us. We need to pay for it, and then we need to send the proper images that are required. The data need to be sent by the image quality needs to be sent every quarter. So 4 times a year, we need to send the images And as far as calibration of the phantom is concerned, we send it when we apply for certification and then once a year. It is important also to inform the team about any important changes, like changing the dose calibrator, or if we change the software or some part of the hardware of the scanner, we need to send the scan and the information and to this institute in order to obtain the proper certification again. It is also important that the doses are synchronized because we inform the proper, we provide proper information about the phantom, the dose applied. It all matters. And then after the accreditation process, we will receive a signet of recognition that you can see here in the slide. Additionally, we are provided with an accreditation certificate, which I will show you in a minute. And we are also included on the EARL Centers of Excellence Network website. So here we can see the certificate for accreditation, which is provided for a particular institution and a particular scanner. So here you can see the number, the name of the scanner along with its individual ID number. So as I said, we need to provide all the images 4 times a year. And here on the website of the Centers of Excellence, we can see the whole network of these centers, and we can see which centers have an active accreditation. In Poland, we are the only institution that has the accredited PET-MR scanner. In the West, as you can see, in the Western Europe, there are many more of such scanners accredited, but, well, we are trying to get to this level. Here you can see the whole schedule for QC procedures. So the quality calibration, we need to send the cylindric phantom when we apply for the certificate, and then once a quarter, so 4 times a year. If we have NEMA body phantom, we need to send the image at this when we apply for certification, and then once a year. The phantom is interesting because inside there's a special special input, which resembles the soft tissue. It is not wet, and then we have some heat sources that imitate the hot lesions, and distilled water with a little bit of isotope. In order to obtain such a certification, we need to scan cylindric phantoms once a year or quarterly, and for sure at the beginning of certification. But in order to obtain such a certification, we need to have an active certification for fluor 18, and the same applies for brain fluor. So we need to have an active accreditation for active fluor standard 1 and 2, and only then we can apply for accreditation of brain application with Hoffman phantom. And here you can see that both standards can be used independently or in parallel. Actually, they differ in filtration and construction. So, as I said, we can use them independently or in parallel, so we can have both standards 1 and 2, or just standard 1 or standard 2. So it is all done online via EARL account that we are provided. And then data submission timelines, we can see that every year is divided into 4 quarters. In the first quarter, we scan NEMO body phantom and the cylindric phantom, and then every other quarters we just scan the cylinder only. Then when we want to send the images, we just need to log on on our account, logging in on our account, and we send the images. Here on the right hand side, this is the NEMA body phantom image with some lung tissue imitator. And we can see some spheres from the smallest spheres to the biggest with that imitate the hot spots. It is also possible to rent a phantom from EARL team because not every institution, not every center has such a phantom at the disposal. We need to prepare the phantom for calibration. There is a special cylinder of 20 centimeter diameter, and we need to ensure 70 megabecquerel at the acquisition start. And we can actually add some more activity. There is some scope of activity. We need to place the phantom centrally, and we need to scan at least two bed positions for 5 minutes. So this imitates what we usually do with our patients, and this is what we do with our phantom as well. As regards NEMA body image quality phantom, well, we use spheres with concentration of 20 kilobecquerels of FDG in 1 liter of distilled water, and we need to put it in all our spheres in order to achieve 1:10 background to sphere activity ratio. And then we position the phantom on the scanner bed. But of course, we need to make sure that there are 20 megabecquerels in NEMA body image quality phantom. Then we place it centrally, and the phantom needs to be placed horizontally in the central part. So there are 2 beds, and we scan it for 5 minutes, so it should resemble the routine clinical examination. Here, I would like to show you a video that will show you how to prepare a phantom correctly. This video can be found on YouTube as well. Let me show you the video now.
Once filled, remove 10 to 15 milliliters of water and inject the F18 FDG into the phantom. The syringe should be flushed several times. The remaining activity should be measured in the dose calibrator and recorded together with the time of measurement. These values must be reported to EARL. The phantom must be closed tightly and shaken so the radioactive solution is uniformly distributed. After homogenization, reopen the port and replace the previously removed water to fill the phantom. The phantom can now be transported using a trolley to the PET-CT scanner. In the scanning room, it is important that the time on the scanner is synchronized with the time you are using for the activity measurements. Position the phantom on the PET-CT scanner using the holder normally used for scanner calibration. Perform a scan using acquisition parameters set up for a PET-CT FDG study covering 2 bed positions. To ensure low levels of image noise, acquire for at least 5 minutes per bed position. This test is used to verify the accuracy of the scanner's activity calibration relative to the dose calibrator. The second experiment focuses on the calculation of standard uptake value recovery coefficients. This uses the NEMA 2007 image quality phantom, which contains 6 spheres of different diameters ranging from 10 to 37 millimeters. First, we fill the spheres. Prepare a stock solution of exactly 1,000 milliliters of water, preferably distilled water. In order to see the spheres more clearly, blue dye or other colouring material can be added. Prepare a small syringe of F18 FDG, which should be calibrated to be approximately 20 megabecquerels at the time of the phantom acquisition. The exact activity and time of measurement should be recorded and then reported to EARL via the online box. Add the F18 FDG to the stock solution and flush the syringe several times. The remaining activity should be measured in the dose calibrator and reported to EARL via the online box. The time of measurement should also be reported. Homogenize the stock solution. Fill the 6 spheres with the stock solution. You will need a long, ideally blunt needle. Be careful not to pierce the wall of the spheres and ensure that there are no air bubbles. Once the spheres are filled, the main body of the phantom should be filled with water. Prepare a second small syringe of F18 FDG calibrated to be approximately 20 megabecquerels at the time of the phantom acquisition. Record the activity and the time of measurement and report these values to EARL using the online box. Add the activity to the water in the phantom and flush several times. The remaining activity should be measured in the dose calibrator and reported to EARL via the online box. The time the measurement was made should also be reported. Tighten the screws on the phantom to ensure that there will be no leakage. Be careful not to over-tighten these screws as they can easily break. Shake the phantom to ensure that the activity is well mixed. The main compartment can now be topped up with more water to ensure that the phantom is completely filled. Place an absorbent pad onto the couch to avoid any spillage. Position the phantom carefully centrally onto the couch, taking care to ensure the phantom is straight. The couch height should position the phantom in the centre of the field of view, and the spheres should be in the same transaxial plane. The scanner's lasers can help with this. Perform a scan using the acquisition parameters set up for a PET-CT FDG study, with 2 bed positions and at least 5 minutes per bed position. At EARL, we compare the absolute SUVs in the spheres with the expected SUV or activity concentrations in the stock solution. The recovery coefficients are calculated as the ratio of the PET measured activity concentration and stock solution activity concentration. The criteria to pass the SUV recovery and image quality test are listed on the EARL website. Further information about EARL accreditation can also be found on the website.
Let's proceed with the lecture. You could see how to prepare the phantom. So it's quite a complex process when it comes to NEMA phantoms. The phantom is very well presented in this video. So the images you obtain have to be sent via online account to the RL team, including the data we need to provide. So it's the data on the activity of the isotope, the residual activity, the time of the start of the acquisition, so on and so forth. Here you can see the example of such a form. So step by step you need to fill it in, and you need to add some images you obtain in the zip format. Another format, the NEMA body phantom, more data is available here because this activity is for the sphere and for the background. So this is the brain phantom. Let's proceed. I would like to show you some example results of validation that you can see after you log into our account. So the validation is beyond the range. It hasn't been approved, but we know why it has happened. We can see that we have sent the images for the standard 2 instead of standard 1, and we didn't attach the right phantom. So it was a technical error. We could correct this. The correct images were sent, and we were accredited. Here you can see some pictures how to position the phantom in our scanner. You can see that the phantom is cylindrical. It is labeled in the central field of view. These are the results of the validation for standard 1 that have been approved. They meet the criteria, and you can see what it looks like. You can see that all the parameters are correct. Here you can see some protocol planning. This is the cylindrical phantom, which the image is quite blurred, is the resonance, the spins are spinning. So this is what it looks like at the beginning. So 2 beds, 5 minutes each. This is for our clinical protocol. This is the phantom scanned. This is our QC calibration. So these are the images after the correction of attenuation. This is the NEMA body phantom. So this is the central part. This is this lung tissue. Here you can see the forces of hardness. So the isotope has been provided, and the background. We have to make sure that there are no air bubbles are in the phantom, because that they would affect the results. So these are the validation results for standard 1, and this is for standard 2. They have been approved. And here you can see that we have some more data analysis. So here we looked at the mean SUV, maximum SUV, and point SUV values. Under the standard 1, we have the peak and minimum SUV. I know that we are running out of time. So this is the compilation of standard 1 and standard 2. This is the data analysis. You can see there are some differences due to different reconstruction parameters and different infiltrations used for the images we have to send. So, of course, this is teamwork. You couldn't work on your own, so it's me and our colleague, our electroradiologist, physician Marcin Podolski, who has a great impact on maintaining our certification. So thank you very much for your attention, and if you have any questions, you can send them to us by email, or you can ask them right now if we have some time.